Hello, my name's Dr. Curtis Thompson. I'm a skin pathologist who specializes in biopsies for hair loss. So, as I've said before, we do biopsies to confirm diagnoses or when we don't know exactly what's going on. I wanted to start by putting in a plug once again for the Alopecia Summit in New York City on December 13th and 14th. And this is a good opportunity for clinicians to hear good lectures from clinical hair loss experts and pathologists like me over 2 days. So the case I want to show you today is a biopsy that's done on a very young 33-year-old woman with diffuse hair loss. So it's over her entire head. And I start out with this. It's a colloidal iron stain, which stains mucin. And you can see the hairs here transversely. And then you notice there's one that lights up more, and that's the mucin stain right here. So that's suspicious for a scarring or a cicatricial alopecia. And then you notice something's going on here. So if we go up, we also always have a fungal stain, and you can see the patient has flaky orthokeratosis, typical of seborrheic dermatitis, and then abundant yeast. So we now have a diagnosis of seborrheic dermatitis with yeast, or commonly known as dandruff. So if we go to the biopsy, this is the skin surface when we're just transversely at the top going deeper and deeper. And you can see here, right now, what we notice is a hair follicle that's very altered, and then it's full of neutrophils or pus. And this is an acneiform lesion, like you might get on your face also. You can get them on your scalp. And so this is a clinician that was evaluating the patient for hair loss and then went to do the biopsy and probably saw this juicy red area and biopsied this, but this isn't part of the reason the patient has the hair loss. And this is that follicle with the perifollicular mucinous fibroplasia that I showed you. And the point here is we're not seeing anywhere else. And this is a zit, an acneiform lesion. And so this is a resolving zit, in my opinion, and it doesn't represent a scarring alopecia. So if we go deeper in the biopsy, the sections as we go deeper down to the subcutis, you can see there's a generous number of hairs still, and we see that zit right in the middle. And when we get down at the deepest areas, you can see once again there's high variability in the size of the hair follicles. So as I've said before, you start out life with a large follicle, and when you have this androgenetic alopecia, or in this case, female pattern alopecia, every time they cycle, they get smaller and smaller and smaller, and that's when we see the hair loss. And if we go up a little bit higher, then I've marked the catagen telogen, or the cycling hairs, because we want to evaluate whether the patient has a telogen effluvium also, which is when you have shedding of hair from like low iron, low protein, different causes, COVID even. So I identified 4 of these. And when I count all of the hairs, and I count them in twos, 2, 4, 6, 8, 10, 12, 14, 16 in this half, 18, 20, 22, 24, 26 hairs total. So that's a normal number. This is a 4 millimeter punch. So you have 12.56 square millimeters. And when you divide that out, you come out with just a little bit over 2 per square millimeter, which is normal. And then we have 4 of these catagen telogens, and 4 out of 26 is about 15% in catagen telogen. And this is what I consider a normal. This is high normal. Above that, you start talking about a telogen effluvium. But I consider this high normal in a young woman who has an androgen-driven female pattern hair loss. So now we have our diagnosis. We have female pattern hair loss, androgenetic alopecia. We have seborrheic dermatitis, and then we have incidental acneiform lesions. Thank you. Have a good day.